right, good morning. So in this PowerPoint, I'm going to be talking about the brain and concussion, and as well as some other aspects of head injury. And just so you know, on a lot of this, the research is going to change tremendously in the next year. So this is like an update from my previous kind of brain and concussion one, but is by far not complete because I'm still waiting for the worldwide symposium, which should be fall 2022 in Germany, I believe. So from there, we're going to have a tremendous amount of new items. There's supposed to be previously, COVID happened, so they couldn't have that. So we haven't had a lot of new research come out in the last probably 3-4 years because of that. But a lot of the stuff is going to be very groundbreaking. Even some of this, which I got a lot of from the conference, a lot of information on this just came out. The studies and the articles just got published. And definitely a lot of it is going to change. Okay, just be forewarned. Okay, so the bones of the skull. Okay, down here we have the occipital. Okay, down like the base of the skull up here. We have the temporal bone. Okay, on each side of the brain, each side of the head. We have the parietal. Okay, so parietal is two different segments up here. Frontal bone. Okay, forehead, if you would. Okay, and we have an ethmoid bone kind of right here inside the eye socket. Okay, and those are held together through a lot of like sutures. That's pretty much once you hit a certain age. I can't remember the exact age off the top of my head. The bones are all fused together. Okay, but there's not a lot of movement between these joints. There's just different segments of the bone. All right, and the brain. So the central nervous system. And forgive me if I go through this kind of quickly. It's kind of a long PowerPoint. The brain and the central nervous system. Okay, so the brain and spinal cord make up the central nervous system. Okay, that's it. All the peripheral nervous system, which everything that comes off of the spinal cord, which innervates pretty much all your other nerve endings, muscle innervations, all that stuff. But just in terms of your central nervous system is just your brain and spinal cord. Okay, your cerebrum or cortex, okay, largest part of the brain, two different kind of hemispheres. I'm in here. Coordinates all voluntary muscle activities. Okay, interprets all the sensory impulses that come from anything else. Let's say movement. Okay, touch, feel, all of that gets interpreted. And like, all right, so I'm going to voluntarily take my hand off of that hot item, for example. Okay, also helps to control higher mental function. Memory, reasoning, intelligence, learning, judgment, emotions. Okay, all that happens in here. Motor cortex, okay, in this area right here. Role as primary motor, is to generate neural impulses that control the execution of movement. Okay, so this starts that execution, okay, or that initial thing of like, hey, let's send a nerve signal or impulse, okay, to start that initial movement. Okay, somatosensory cortex, responsible for processing somatic sensations. Sensations arise from receptors positioned throughout the body and are responsible for detecting touch, proprioception, narcoception, pain, and temperature. Okay, and this also helps you realize that you are touching something. Okay, let's just say it right in here. Frontal lobe, okay, in here. Plays a key role in future planning, self-management, and decision-making. People with frontal lobe damage often struggle with gathering information, remembering previous experiences, and making decisions based on any input. I believe it is one of the areas of the brain that develops later on, okay, or is not fully developed until you get to like a certain age. So that's why a lot of times, like I have a young son, 4 years old, tomorrow, and he doesn't have a lot of decision-making things planned, but he's still growing. Okay, so when you tell him, all right, do not touch the hot iron, and he looks at you and be like, you know what, I still want to touch it. Okay, he has poor decision-making at this point. That's just because he's a kid. Okay, all right, temporal lobes here on the side. play a key role in auditory processing. Okay, so hearing, because it's, again, your ear is like right here, right next to it. It's how you perceive sounds, assign meaning to that sound, and remember sounds. Okay, formation of visual memories, okay, including long-term memories, are also helped processed in here. Okay, interprets the meaning of any visual stimuli, language recognition, helps produce speech. Dysfunction in this area can lead to difficulties speaking, even when the other structures are intact. Okay, so in terms of like head injuries, all the time in like contact sports, the force is from the side. Okay, going from one side to the other. Okay, football tackling, rugby, whatever it is, usually there's a hit to the side of the head at some point. Whether it's you turn your head to make the tackle, okay, but you're tackling around in here, okay, impact is still going through the temporal lobe, so that can have issues with talking, with hearing, bringing in the ears, that kind of stuff. Okay, so just because of the area right up in there. Parietal lobe, center of somatic senses, case touch, pain, pressure, temperature, helps to understand spatial relationships, and correctly analyzes and compare positions of the body. Occipital lobe, okay, helps with spatial reasoning and visual memory. Most vision involves some type of memory. Excuse me. Determines color properties of the item, visual field, distance, size, depth. Okay, so occipital lobe is down here at the back, and your ocular nerve, okay, so your eyes are up in here, right, goes all the way through to the back, and kind of is, I don't know, it's not innervated, but attaches to your ocular lobe. Okay, so when you like hit the back of your head on something, okay, or whiplash, head flips forward and then back, okay, and impact of your posterior side of your brain, which is your ocular lobe with your skull, okay, it can affect your vision. Okay, also helps identify visual stimuli, faces, objects, transmits visual information to other regions of the brain, so it can process it, encode memories, meaning to whatever that visual stimulus, and so forth. Okay, the cerebellum, okay, controls the synergistic, okay, whole body movements, usually skeletal, plays a critical role in coordination of voluntary and of the muscular system. Okay, the limbic system, okay, involved in behavioral and emotional responses. Consider the primitive brain, if you would. Concerns with hunger, motivation, sex drive, mood, pain, pleasure, appetite, memory, emotions, and memory. Sorry, excuse me. Okay, and this includes the thalamus, the hypothalamus, the amygdala, and the hippocampus. Now, depending on what research you look at, they could have either a little bit more items in for the limbic system, or like one less. They're not too clear on what everything is encased within that. So depending on, like, some doesn't have, I think it doesn't have the thalamus, but some others do. So just keep that in mind. So the thalamus, okay, main relay for all sensory information except for olfactory, smell. Okay, that's just the cranial nerve that deals with smell. Is scent. Okay, so the thalamus, I'm not seeing here. Okay, right in here. Okay, so all your sensory information gets sent here. Okay, regulates sleep, wakefulness, and arousal. Okay, the hypothalamus keeps the body in a hemostatic state. Okay, it controls the pituitary gland, which produces hormones, maintains physiologic cycles, appetites, sexual behavior, emotional responses, body temperature. Okay, so that homeostasis is a big item right there. Okay, so that's just keep your body in this kind of like neutral, healthy state. So like if you get too cold, you shiver to warm yourself up. If you get too hot, you sweat to cool yourself down. Okay, that's the example of a homeostatic state. Okay, amygdala, okay, regulates emotion and memories. Found in the temporal lobe, responsible for producing emotions such as fear, pleasure, and anger. Okay, hippocampus, okay, located deep in the temporal lobe, fragile and can be damaged through stimuli. Excuse me. A lot of neurochemicals are which can damage that. Vascular abnormalities can as well damage the hippocampus. A lot of whatever mild traumatic or major traumatic brain injuries can definitely affect vascular supply to the brain in general, and the hippocampus is just very fragile. Okay, important for memory recollection, learning, and memory building, and converting short-term memory to long-term memory. Okay, the brainstem, okay, with the pons, which relays information between the body and body, excuse me, typo there, connects the cerebral cortex and the medulla oblongata. I have a hard time saying that. Okay, half the cranial nerve relays info here. Okay, helps control sleep, posture, breathing, swallowing, and bladder control. Okay, the medulla oblongata, okay, the lowest part of the brain and connects to the spinal cord, regulates several autonomic functions, okay, respirations, cardiac function, vasodilation, reflexes. Okay, and here's just a little like snippet from the Water Boy. If you've seen it, you know what I'm talking about. If not, I'm not going to play it for you, okay, just for simplicity's sake. Okay, if you haven't seen it, it's not a bad movie to watch. It's funny. It's stupid funny, but there you go. All right, midbrain is an anterior portion of the brainstem associated with motor movement, vision, hearing, sleep and wakefulness, arousal, usually the alertness, and temperature regulation. All right, so that's kind of a quick intro on the brain. So now the meninges. Excuse me. Okay, so meninges is, there's three different layers of the meninges: the dura mater, the arachnoid mater, and the pia mater. Okay, this is a little video that will talk about things a little bit more in depth. See, for time reasons, I'm just going to talk about a lot of those in general. Okay, so the dura mater is the outermost mater. Okay, right in here. Okay, very dense, fibrous, kind of like an elastic sheath that encloses the brain and spinal cord. So your meninges cover your brain and spinal cord. Okay, that's all it does. Okay, it makes a nice barrier between the two. Okay, not between, around it all to separate pretty much the central nervous system from the rest of the body. Okay, the arachnoid mater. Okay, in here, arachnoid like spider, because it's kind of like a spider web, if you would. Okay, extremely delicate, lines the dura mater and attaches directly to the spinal cord. So it helps make this kind of subdural space in here, which a lot of like veins and arteries can pass through. Okay, and the pia mater, this kind of undermost kind of layer, thin, delicate, highly vascularized membrane that adheres closely to the spinal cord and brain. Okay, so that is a meninges, this area right here. Okay. Now we're going to talk about some specific head injuries. Cerebral concussion, which is a mild traumatic brain injury, post-concussion syndrome, secondary impact syndrome, cerebral contusion, malignant brain edema syndrome, sub and epidural hematomas, migraine headaches, and traumatic encephalopathy, or CTE. Okay. So a brain bruise, a cerebral contusion, involves a small hemorrhage or intracranial bleeding somewhere in the brain, brainstem, anywhere. Usually a result of impact from injury of the head hitting an object. So whatever object that is that hit the head can vary tremendously. Whether it's another player, car accident, you hit your steering wheel, airbag. One thing that people forget about in terms of athletics is the ground. The ground is a really big mechanism of injury, if you would, that can cause contusions, brain bruises, whatever it is. Just because the ground is very hard, okay? Or what on the ground did you hit? Is it grass? Is it concrete? Is it asphalt? Is it a lip? Is it a sprinkler? You never know. It varies. And then depending on the season of the sport, that can vary a lot. Okay? In terms of soccer, Collegiate soccer is a fall sport. Okay, it's very hot. High school soccer is a winter sport. It's super cold. The ground's frozen. Okay, so the ground can be almost like concrete in a way during some of those colder months. Also, how prepared is that ground? Okay, let's say it's soccer, for example. Okay, how is that field? Is it prepared nicely? Is it early in the season when it looks somewhat nice-ish? Is it late in whatever that season is, whether it's football or whatever it is, where it's just kind of mud, all the grass is dead, everything's super compact? That's important things to monitor. Okay, and going back, so a cerebral contusion is a severe traumatic brain injury. Okay, because you do have some kind of hemorrhage, okay, going on in there, and hemorrhage is just bleeding. All right, malignant brain edema syndrome. Okay, the diffuse brain swelling resulting from excessive blood or vessels, which produces too much intracranial fluid. Okay, increases pressure within the brain. Too much stuff going on in the brain pushes the brain out. Okay, so what they do a lot of time is some kind of craniectomy. So they actually take off part of the skull. Okay, this is a serious and life-threatening consequence of a whatever condition that raises intracranial pressure substantially. Okay, rapid neurologic deterioration from a normal alert state that progresses to coma and occasionally death within minutes to several hours. Okay, so obviously not the best in the world. Okay, so if you have this, whatever it is, you're not going to come out completely normal again. Okay, there's going to be some kind of neurologic defect. It could be minor, it could be severe, but usually you're not going to come out normal again. Okay, I'm not even talking about looks. Okay, this is how you process and move and do a lot of different things. All right, next is epidural hematoma, okay, followed by subdural hematoma, just so you know. This is a blow to the head or skull that causes a tear of the meningeal arteries. These arteries are embedded within the bony grooves of the skull. Due to the arterial blood pressure, blood accumulates, which results in a creation of some kind of hematoma, okay, or pooling of blood. Epidural hematoma takes place under the skull above the dura mater. Okay. Say because epidural, okay, epi means above the dura, okay, which is part of the meninges. Okay. So this side here, okay, the other side subdural. We'll talk about that here in a minute. Okay. So this is actually a push, almost like a balloon, on the meninges because of all this excessive blood. It's going to push in on the brain. Okay, which is obviously a bad thing. Okay, so that is a epidural hematoma. Okay, so it's between the skull and the meninges. Okay, some kind of pulling of blood. The subdural hematoma is, I don't want to say it's any better or any worse than the epidural hematoma, but it results from some kind of acceleration and deceleration force that tears the vessels that bridge the dura mater in the brain. Okay, so what's the difference is this is usually underneath the meninges, or the dural lining, so the blood can seep into the brain at this point. To where the epidural is kind of above the brain, this one is underneath that dural lining and it can seep into other areas of the brain. Okay, the patient can be conscious or unconscious for any of these. Both are life-threatening situations. Okay, signs and symptoms of epidural subdural hematoma: elevated blood pressure and decreased pulse, okay, also called the crush reflex. Severe headache, confusion, dizziness, altered level of consciousness, unequal pupil size, nausea or vomiting. Biggest thing is unequal pupil size because your pupils, okay, your eyes, is pretty much a window into your brain. Okay, that's where like the pen light, which we covered in class, or if you were not there, or I didn't cover it whenever you're watching this, I'm going to talk about it briefly here in a little bit. Okay, but a lot of these here is other signs of a concussion: headache, confusion, dizziness, also level of consciousness, nausea, vomiting. Not too often you're going to see with a normal concussion unequal pupil size, but it's also really good to have blood pressure and pulse, okay, because you're going to see a difference pretty much every 5 minutes, 3 to 5 minutes, on maybe blood pressure is going to keep going up and pulse is going to keep going down. Okay, so vitals are very, very important in that. All right, migraine headaches, excuse me, can last several hours to days. It's a neurologic disorder with an unknown cause because everyone can be different that gets migraines. Many factors that trigger migraines could be foods, medication, sensory stimuli, flickering lights, bright lights, odors, smells, whatever it is. Can obviously disrupt normal activity. Pain may be accompanied with nausea, vomiting, sensitivity to light, smell, or sound. Some experience in aura, okay, like a sixth sense if you would, 10 to 30 minutes before the migraine starts. Can include visual changes, blind spot, zigzag lines, loss of vision on one side or both. Okay, like for me, I get migraines when I watch 3D movies. Okay, so any like 3D movie with those glasses is terrible for me. I mean, I'm pretty much done for the rest of that day at least. All right, concussion or mild traumatic brain injuries. Okay, so for this, for one, I want to ask, what do you think is a concussion? Okay, what have you like to learn in the past? What have you seen in the past? What have you heard? What have you learned? All that stuff. Some common terminology that you've probably like seen or heard used, or you've used yourself is, "Oh, I got dinged. I got my bell rung," or "I'm trying to clear the cobwebs." So that is some terminology they're trying to not use anymore because that is pretty much signs of a concussion. And it's just bad terminology for one. Okay, so I'll get more in depth on that. For first, what are the signs and symptoms of a concussion? Okay, so take a minute right now, okay, and just think of all the different ones out there. Okay, because there's roughly about 22. Okay. All right, so keep that in mind. Okay, and see if we add more as we go on. Okay, so official definition, I have 2 different sources here. There's obviously a lot more sources out here on concussion. So the NC2A Sports Medicine Handbook has a concussion is a change in brain function following a force to the head, which may be accompanied by temporary loss of consciousness, but is identified in awake individuals with measures of neurologic and cognitive dysfunction. Okay. The National Athletic Training Association Concussion Management Position Statement, which came out in 2004, I believe, and they're updating that very quickly right now, is a trauma-induced alteration in mental status that may or may not involve loss of consciousness. Okay, so both has some kind of alteration, okay, mental, neurologic, cognitive dysfunction, okay, so something's not processing correctly. Okay, so both have that. Next thing is loss of consciousness. Okay, before they used to think, like early days, that concussion was only loss of consciousness. Even going back about 20 years, they had ratings, and it went off of the biggest rating factor was how long was the loss of consciousness. Okay, and then now it's pretty much like gone. So anything that alters mental status, okay, is a concussion. Okay, that involves some kind of traumatic mechanism. Okay, and the mechanism of injury that can cause said concussion doesn't have to be to the head. It can be the body. Okay, it can be just a hit to the body or falling down, but you never hit your head because I think your head is like an egg. The skull is the shell, and the brain's the yolk. Okay, which just floats inside and it rattles back and forth and twists and moves and does a lot of different things. Okay, so a hard hit to the body can cause pretty much the brain to shake within the skull, okay, and cause some kind of different abnormality. And all the loss of consciousness, I've never seen any. I've seen hundreds of concussions. Okay, I've never witnessed a loss of consciousness. Not saying it doesn't happen. I'm just saying I've never personally witnessed it, and I've witnessed a lot of concussions. All right, so how do you diagnose a concussion? Okay, so we have MRI, we have CT, we have EEG, which is the electroencephalogram that measures brain activity. We have X-rays and blood tests. Okay, so out of all these 5 here, which one or ones do you think helps diagnose for a concussion? I'll give you a few seconds. All right, so if you think MRI does, you're wrong. If you think CT, or computerized tomography, diagnoses concussions, you are wrong. If you think electroencephalogram diagnoses concussions, you are wrong. And X-rays and blood tests are also wrong. Just put that in there. Okay, so the importance of the MRI and CT is it can help you kind of identify, well, not too far, items of a sub or epidural hematoma. Okay, very, very important to know, obviously, because these are life-threatening situations. Okay, but those can help identify because you can actually see the pooling of blood. Okay, so those are very important, but it doesn't help diagnose for a concussion. Okay, electroencephalograms, EEGs, and that's where they have like wires placed over like the section of the head. Does not assess for concussions. It measures brain activity, which your brain's still active during a concussion. Okay, it's just not functioning properly. Okay, so, and I think a concussion is a mild traumatic brain injury. Okay, it's not going to show anything. It's only going to show up more on the major traumatic brain injuries. Okay, then X-rays. Okay, obviously does not diagnose concussion, but can lead to any kind of skull fracture. Okay, which can lead to more life-threatening conditions. And then the past 10 years, there's been a big talk about blood tests being a big component into assessing, predicting, diagnosing concussions. But that is more so the media trying to do that. When they came out and they say, we do blood tests to help rule out MRIs. Okay, that's all they do. Okay, they'll do like a blood test to rule out doing an MRI. Okay, which can show those crazy bad epidural subarachnoid hematomas or other kind of factors. Okay, but it does not help diagnose for a concussion. Okay. Next, cerebral concussion. Okay, can be direct or indirect blow. Okay, below the head can produce 2 types of injuries. Okay, so you can have coup or counter coup. Okay, or combination. Okay, so coup injury is at the point of contact. Okay, where a counter coup injury occurs at the opposite side of said head. So I still have the contact here. Okay, so I can still have damage to this side of the head, but as my brain shifts over and hits this side of my skull, now I have an injury to this side of that brain as well. Okay, and so whiplash. Okay, you get hit from behind. Okay, in the car. Okay, your head shifts forward. Okay, so my brain hits the front of my skull here. Sorry. Okay, and then as it goes back again, it hits the back of my skull. Okay, so counter coup injury. Okay, this can result in widespread microscopic damage that cannot be detected through imaging. Can make the brain cells sick, if you would, okay, without killing them. Can result in a lot of anxiety, depression, and emotional disturbances, okay, through some of these. What does happen is, I'm going to get too ahead of myself a little bit, is when the brain shifts, this microscopic damage is the shearing and stretching out of these nerves. Okay, because your brainstem and everything, and your spinal cord, that's all pretty fixed in because it's in a set vertebral column and goes to a specific hole in the base of your skull. Okay, so there's not a lot of movement that occurs there. That's very fixed. So then you have this other bigger item, your brain, okay, that isn't fixed, which can move around. Okay, so that shearing, okay, and twisting which can stretch out a lot of your nerves, your axons, can really play a big role in cerebral concussions, okay, which could be one of the main indicators of that. And there's others I'll mention. All right, post-concussion syndrome. Okay, so this is a condition that may occur after sustaining a concussion. Okay, symptoms can begin immediately or within several days that can last for weeks or months before resolving. So the worst injury I've ever seen in all of my times working with athletics has been a concussion. Okay, the doctor took this individual out of school for a year. Okay, not allowed to do any schoolwork, nothing. Just based on the amount of symptoms and how long it lasted. So her post-concussion syndrome lasted over a year. Okay, and the symptoms can include persistent headache, impaired memory, lack of concentration, anxiety, irritability, giddiness, fatigue, depression, visual disturbances, like the works. I mean, there was like more than 9 months later, and she's still throwing up from the pain from headaches. And she's like, visual disturbances. She's like blind from the headaches. That's how bad these were. Okay, and she couldn't do any schoolwork as a result, so she pretty much had to redo entire grade. Just because any kind of thinking or cognitive function, okay, which removes tremendous headaches for her, as well as a number of different things. Okay, so a lot of people do experience some kind of post-concussion syndrome after this kind of injury, but everyone varies so much on how long it lasts and so forth. All right, secondary impact syndrome. Okay, so secondary impact occurs because of a rapid swelling and herniation of the brain after a second head injury occurs before the symptoms of the first one are resolved. Okay, so you get a concussion like Monday. Okay, you don't tell anyone, you don't tell coaches, athletic trainers, doctors, whatever happened. Okay, that you got it, because a lot of people do hide it more than you think. Okay, let's say it gets better. Okay, but still have a little bit. Okay, and let's say Friday or Saturday you get another big hit. Okay, another big concussive blow. Okay, but you still have symptoms of the first one. Now you can have secondary impact as a result. Okay, there's a 50% survival rate with secondary impact. This is pretty much the main reason we pull individuals from participation in activities, because we don't want this. Okay, usually when you hear in the news of like this person died from a concussion or is in a coma, whatever it is, that is secondary impact syndrome. Okay. What else? You get this widespread, the brain loses the ability to self-regulate pressure and blood volume, resulting in extreme swelling of the brain, okay, which happens very, very quickly. Usually within 15 seconds to several minutes. Okay, very, very bad. And all my links are not playing right now. Okay. All right, so symptoms of a concussion, okay, immediate or delayed. Okay, what do you think? Do all your symptoms come on right after like injury or delayed? Okay, the answer is both. Okay, so most of the time you're going to get a lot of symptoms immediately after injury. Okay, so this guy got pretty much slammed to the ground. Okay, he's obviously going to have some like left side like head pain, probably some neck, whatever. Okay, but it could take a full 24, 48 hours before all the symptoms kind of come on. Okay, it takes longer on some people versus others. Okay, so even though he got like rocked and he got fine, there's no issues. A lot of times we'll still take some individuals out of activity because we don't know what's going to happen. Okay, first occurrence for multiple concussions. Okay, so how many concussions has this person had? Okay, is this their first one? Is this their 10th? Is this their 7th? The craziest thing I saw was, it was a long time ago. It was like the first year I started practicing. And I was covering a middle school football game in Clovis. Which in Clovis, middle school football is full pads. Contact, everything. Because they have money to afford all that. First thing you fight is, I think, flag. Okay. because they're a little bit smarter. Like, we're not going to spend a tremendous amount of money for these kids to play tackle football, which makes sense. But anyway, it was a 7th grade football game. This kid gets a concussion. Cool. Do my eval. Okay, go and talk to parents. Okay, mom's like, this is his 7th concussion. And I'm like, what are you doing? Okay, no 7th grader should have 7 concussions. Okay. Okay, at that point, she was like, yeah, we're just going to take him out of football together. I was like, absolutely. And probably get a lot of, like, neurologic, like, testing done, because that is not right. But that was before the law went into effect on it. And a lot of people didn't have any training at that point. And that was a lot of, like, issues with that. Is you have a lot of individuals super young getting a substantial amount of concussions super early on. Okay. And the more concussions you have, the easier it is to get them and the longer they last. Okay. It goes up exponentially. Okay. Not saying the first one's the best one, okay, because the first one could be pretty catastrophic in itself. Okay. How long in between occurrences did it happen? Okay. Is it, or like, let's say during that one like season, okay, how many concussions do they have? Okay. Then one happened, let's say week 1. Then the second one happened when? Okay, is it week 3? Okay, well, that's probably still symptoms from his first one. Okay, he got flared up, so he could possibly have second impact, post-concussion, a number of different things. Okay. Maybe symptoms didn't go away completely. Not all healing occurred, or not enough healing occurred before that second, third, fourth concussive blow came on. Okay, important things to keep in mind. All other additional factors. Okay, does the individual have ADHD, migraines, learning disabilities, mood disorders, diabetes, cardiovascular issues, like whatever it is. Okay, those are factors that can tremendously affect outcomes, longevity, and so forth. All right, CTE. So CTE, traumatic encephalopathy. This condition is associated with repeated blows to the head, usually with athletics such as football, boxing, as well as military. Excuse me. This is a degenerative brain disease where the tau protein malfunctions. It's just the protein in the brain. There's a lot of them. Okay, this dysfunction causes a chain reaction spreading throughout the brain, killing brain cells. Okay, it's only diagnosed through autopsy. You can suspect it. Okay, before then. Okay, but just go from this like normal healthy brain to a more kind of like a very advanced CTE. Okay, where actually death of brain cells. Okay. So NFL is under a lot of like heat right now. We're always under a lot of heat for a lot of this. A lot of players have already donated their bodies post-mortem for a study. Boxers are super common to have this because obviously they take a lot of hits. Okay. And then military, they go through tremendous amount of repeated concussive blows, if you would, that can affect this. Okay. Here's a few videos. Okay, I'm not going to show the videos on this because, for one, videos do not show very well. Okay, you'll be able to watch this. I'll try and put them in the canvas as well, so you can watch them as well. It's a little bit more on CTE, or you can go to the VAB CLF Brain Bank. Okay, this is right off their website. Okay, they're pretty short videos. I think they're like 3 minutes long. They just talk a little bit like what is CTE, what are the symptoms of CTE, and so forth. All right, some of the rules and laws into effect. Okay, so AB 25, okay, which is a California law, and CIF bylaw 303, okay, and they say pretty much the same language. Okay, and this is all related to Play It Safer. So this is a student athlete who is suspected of sustaining a concussion or head injury in a practice or game shall be removed from competition at that time for the remainder of the day. A student athlete who has been removed from play may not return to play until the athlete is evaluated by a licensed healthcare provider trained in the evaluation and management of concussion and receives written clearance to return to play from that healthcare provider. Okay. This is more the CIF wordage. The AB25, I believe, takes out the student athlete aspect from all this, and it's just pretty much any individual. Okay, so that could be in bands, club sports, what else? Church ball, whatever it is. Okay, that is suspected. Okay, keyword suspected. Okay, both of these have suspected. Okay, sitting a concussion or head injury. Okay, which can be anything associated with the head. Okay, practice or game removed for the remainder of the day, no matter what. Okay, if the doctor says he's good to play that day, it doesn't matter. Okay. Also make sure they're evaluated by a healthcare provider. Okay, training, evaluation, and management. Okay, and have written clearance to return. Okay, licensed healthcare providers, according to California, okay, only California, is MD and DO only. Okay, so a medical doctor or doctor of osteopathy, which is pretty much the same thing. Just know that. Okay, personally, I actually like DOs. They're a little more holistic in their approaches than MDs. I'm not saying MDs are bad, but just more of NDOs. Okay, they're not as common here in the Valley. I guess they're becoming more common now than in the past, but they're the same thing. The requirements, the education's all the same. Just know that. Okay, no chiropractic, no PT. Athletic trainers, okay, can diagnose, but not under California law. Okay, that's more like a national thing, but not under California. Okay, go California. Okay, factors that may modify risk of concussion, duration of recovery. Okay, 1, symptoms. Okay, how many symptoms do they have? What's the duration of the symptom? Is it longer than 10 days, for example? What is the severity of those symptoms, of each symptom? Okay, signs, progressed loss of consciousness. Okay, is it longer than a minute? Do they have amnesia? Okay, do they have retrograde amnesia? Do they have antegrade amnesia? Okay, there's a little difference. Retrograde amnesia is how is the loss of consciousness before the impact, and antegrade amnesia is how is the loss of consciousness after impact. Okay, so how much can you remember before or after the injury? Okay, or both. Okay, and then how does that change every 5-10 minutes or so? Say I had an athlete, and we're in Bakersfield, football, playing a game, and after my eval, after I got him to the sidelines, everything else, I was like, all right, like, what do you remember? He goes, I don't remember the game starting. All right, document that. 10 minutes later, real thing. Similar question, I don't remember leaving Clovis. Okay, and then like a little bit while later, I don't remember the day before. Okay, so now his retrograde amnesia was getting worse and worse and worse. Okay, just as an example. I don't know why I have anything here. Okay, that's all gone. The frequency of repeated concussions. Okay, so how many concussions have they had overall? Okay, big thing to keep in mind. Okay, recent concussion or mild traumatic brain injury. Okay, when was the last one they had? Okay, really, really important. Threshold, say repeated concussions occurring with progressively less impact, force, or slow recovery after each event. So that slow, like repeated, like hits, okay, has a tremendously more damaging than that one big hit. Okay, that's what that means. Okay, that's why like on boxers, okay, they have a lot of little hits, okay, which causes more issues than that one major hit that knocks them out. And then what's the age? Okay, are they child, adolescents, under 18, adults, elderly, whatever it is? Okay, can play bigger factors on this. Is their brain still developing? Is it fully developed? Those kind of things. Other factors, okay, co-premorbidities, okay, that they have migraines, depression, mental health disorders, learning disorders, ADHD, motion or vision sensitivity, personal or family mood disorders. Okay, all very, very important items. Okay, also behavior. Okay, do they have a dangerous style of play? We actually had a high schooler removed from football. Okay, because his style of play was too dangerous. Given he also had a learning disorder. Okay, that he would always lower his head to make the tackle. Okay, well that's called spearing. Okay, it's illegal everywhere because of the high chance of injury to himself, mainly. Okay, in football you're supposed to keep your head up. Okay, because then you can absorb any forces going through. And we're just talking about neck stuff right now. Okay, my head's up, my neck can absorb all those forces. Usually the muscles can. With my head down lowered, okay, my spine lines up directly, and the impact goes directly through. Okay, and I could have blowout fractures. I can become paralyzed. A number of different things if that occurs. Okay, so I mean, and he had a lot. Going back to the same individual, he had like 2 concussions that season. Okay, from spearing. Okay, but he could not learn how to fix his tackle technique, and it was tried. Like we went through like individualized with coaches like tackling techniques, but you could never perform it correctly. Okay, so then at that point we had to remove him from football, from high school permanently. Okay, because of that. Next is sport. Okay, high risk activity. Okay, contact or collision sport, high level of like sport. Okay, all different things that matter. Okay, considerations. Okay, what's actually happening inside the brain? Okay, usually as a result of concussion. Okay, I talked about the shearing and the stretching of like the nerve. Okay, you also get this neurogenic cascade that happens. This is cascade of a lot of different things happening in the brain. Of one thing sets off the next and the next and the next, and it's just this big ripple that kind of goes all the way through the brain of a lot of different things that occur. It could be minor bleeding, major bleeding. It could be your nerve axons don't function properly. Going from one nerve to the other, okay, in between those, that little space in there, which is really tight together, okay, the signal between one to the next is now thrown off. Okay, everything's thrown out of socket, or out of whack. Nerve impulses don't travel the correct way. Okay, so they're going that way, they're not going that way. Okay, which is obviously not the best thing in the world. Or they're not getting all the way through because the nerve is damaged. You have a decrease in vascular supply. Okay, so blood's not getting provided to all the major aspects of the brain adequately. Okay, it's diminished in some way. It takes a long time for that to return. You get a what's the word I'm looking for at the top of my head? The glucose that the brain uses, okay, it gets thrown off. Because your brain's like a sponge, like almost like if you've ever held a brain, okay, it feels like a sponge. It's a very kind of squishy, if you would. Well, if you throw a sponge against a wall, wet sponge, everything's going to go splat and everything's spread out. Okay, so all those any nutrients that the brain needs or is using, okay, gets pushed out. Hormones get pushed out in different areas where they're not supposed to be, where it's needed. It's a big, like, things occur. It takes a long time for that to kind of get back to normal. And what the biggest thing that needs to get back to normal, okay, is blood supply. Okay, is glucose, which is now pushed out, and it takes a tremendous amount of metabolism to get everything kind of back in order, which it can't now. Okay. Next is how many concussions disqualify me from sport. Okay. Obviously, the one concussion is going to take you out. Okay. But how many concussions will remove you permanently from sport? Okay. The number is there is no number. Okay. There's no specific. Everyone's going to say, 3, 4, whatever. Okay. But there's no number. Okay. There will be a point to where the doctor is going to sit down with them and their like parent, for if they're under 18, and say, all right, do you want to actually like live a good life? Do you want to remember like your college or high school days? That kind of stuff. Like how important is this one game to like the rest of your life, for example. And I've had that conversation with a lot of like student athletes and parents. Okay, because like, how important is this JV football game realistically? Okay, it's really not. Okay, no sport is more important than like your longevity of your life. Okay, and the quality of life you can have. Okay, do you want headaches the rest of your life? Probably not. Okay, it's not worth that one game. Okay, and then what causes a concussion? Okay, the mechanism of injury. Okay, I talked a lot about that. Whether it's the neurogenic cascade, shearing, a lot of stuff. Signs and symptoms, I'll go over that here in a minute. How long do they last? Okay, usually on average about 3 weeks. Okay, it's a lot longer than people think. Okay, school considerations. Okay, I'll talk about a little bit of that. Okay, which is the return to learn, which is a really big aspect that they're really trying to push right now. Is how do you get back to proper learning? Okay, before we get back to activity. Okay, because most of this time we're not talking about professional sports. I mean, they're a component of this, but usually, besides professional sports, they're in some kind of institution, college, junior college, secondary school, which is like middle school, high school. Okay, they're in something like that, where grades is a big aspect of that. And if you start failing a class, well, now you can't play sports. Okay, that's the best way I'm going to push it to a lot of athletes that have a concussion. Like, we need to get your grades established, whether it's getting better or maintain them. Okay, because let's say in 3 weeks, when you start coming back to your return to play, okay, and you're failing your classes, well, now you're not eligible. Okay, so you're going to really make sure that we're looking at grades and class accommodations to make sure that they're excelling in the classroom. Okay, before you even care about sports. Okay, but a lot of times those now go hand in hand. Okay, I'm talking about the return to learn as well as the rehabilitation of a concussion, which it does involve some activity. I'll talk about that. Okay, I guess a little bit more on the school considerations. So return to learn is getting back in the classroom. So as soon as they can start going back to class, like, by all means, okay, let's get them back in school, okay, but safely. Okay, some things to keep in mind on this is we don't want to make any of the symptoms worse. Okay, so if at any point on any of this symptoms get worse, we need to turn it back. Okay, so this can be some things as what's going to cause their headache. Okay, a lot of people, when they get a concussion, okay, headache's like, okay, let's say it's a 1 out of 6, right? Very mild. This is like 2 days after injury, 2-3 days, okay? Okay, let's say it happens Friday, Saturday, okay, they're back like Monday, Tuesday, the classes. How are they tolerating school? Are lights too bright now? Do they need glasses and a hat? Okay. Will the teachers allow glasses and a hat in the classroom? Okay. Going back to some schools, no. Okay. But like, there's a reason for it now. Okay. So now we're decreasing like light intake, maybe in a quieter side of the classroom in the corner. Okay, where it's not as super bright. You maybe can shut off like those lights in that area. Keep those things in mind. Next is sound. Okay, how loud are some of these classrooms? Are you in a metal shop where something's super loud? Are you in an athletic class? Okay, we're excluding activity this time. Where there's a lot of whistles being blown. So earplugs are great. Okay, let's muffle that sound. Also is the overstimulus. Okay, that can happen because your brain is very much after an injury. What's the word I'm looking for? It's very raw, I guess. It can't take in a lot of items. Okay, it gets overloaded. Okay, so like end of class. Okay, when everyone gets up at once, that stimulus, okay, of taking all information visually can overstrain the brain and process it and cause a headache. That in terms now add in noise, okay, because you have a bell, which can be super loud depending. goes off, which can overstimulation. Then everyone talking at once because like, oh, we're here for lunch, we did this and that, you're about this drama, whatever it is. Okay, we'll have all the movement. Okay, can overstimulate the brain. Okay, so how can you reduce that? Okay, you can give glasses, hat, or just glasses. Okay, glasses, hat, earplugs. Okay, that can help depending on the symptoms given. It all depends on symptoms. And then like maybe release them a few minutes early so you can get to the next class, okay, before all the chaos. Wandering the halls in between classes, okay, all that stimulus. Okay, by reducing that, you reduce their symptoms, which can allow them to return to learn more efficiently and even faster. Other things is longer times for assignments if they need it. Only if they need it. Not everyone has to have everything. Okay, so longer times for assignments, for tests. Maybe have different forms of the test. Okay, instead of a written test, okay, they can do it just like one-on-one with the instructor, like kind of Q&A. Okay, so someone will sit across from me, like, all right, and I'll just read off of it. Okay, question 1. Okay, what or how many concussions? How many concussions disqualifies you from participation? Okay, and so they can just tell me verbally, okay, without having to like look and read and answer, okay, because that may be easier for them and not cause further issues. Also, during some of these aspects in class, have them be able to put their head down. Okay, they can still hear it, okay, but all the hearing and visual stuff at the same time is always too much for their head. Okay, naps. Okay, really important. Talk about sleep quality here in a minute, but I'll kind of combine a little bit. Okay, for one, like naps and sleep is the best rest for your brain. Okay, so return to learn, they may need to take like a nap, like middle of the day. I mean, just a quick 10-minute power nap, rest just to kind of like let their brain rest as much as possible, okay, from overload. Or have like an area like the nurse's office, athletic training facility, wherever it is, so they can go and just take a little like 10-15 minute break in between. Okay, just because there's too much stimulus. Okay, and then even going with like homework, okay, or readings, it's going to be like breaks every so often. Okay, maybe only read for 5 minutes at a time. Then I'm going to take a 5-minute break, and then each day as it gets better and better, I'm now going to read 20 minutes at a time and take a 5-minute break. Okay, so once symptoms start getting worse and worse, actually when they start getting worse, okay, take a little break. Okay. Home considerations. Okay, so how is home? Is there areas to where they can, I don't want to say get peace and quiet, but do they have an area like their room, okay, where they can rest and take breaks every so often? Okay, just like school. Okay, or are they sharing a room with like a sibling? Okay, they need some place where they can take some time and have like a designated like rest spot. It's not like a permanent place. Okay, it could be temporary. Okay, maybe it's a den or whatever it is, someone's bedroom. Okay, we can go maybe take like a little nap throughout the day. Okay, because sleep is going to be very important. Okay, and avoid anything that really strains them. Okay, if looking at a phone strains them, okay, obviously let's try and limit the phone usage. Same with computers, reading, noise. Okay, how much noise? Okay, they have a lot of little siblings at home. Okay, can they escape that for a little bit at different times when they get overloaded? Okay, there's a lot of different factors, and everyone's going to react differently. They're going to sleep. Okay, how much are they sleeping at night? Okay, they want to get 7-8 hours of sleep. Okay, at least, especially right after injury, that night of sleep, they're going to get. I mean, I've seen people sleep 18 hours. Okay, and wake up exhausted. Not because they overslept, because it wasn't enough. Okay, for one, it is a myth to keep someone up after a concussion. Okay, do not keep them up. Okay, if they are tired, okay, let them sleep. them take a little nap. You'll be able to wake them up. Okay? They will not go into a coma if they fall asleep. That's absolutely a myth. Don't do that. Okay? Sleep is the best rest for the brain. Okay? And then what is the quality of sleep? Okay? Are they in an area where like no alarms are going to bother them? Don't have them look at their phone a lot before they go to bed. Can they sleep all the way through the night? Is it like a very dark room, or is there too much like light coming into the windows? Do you like blackout like curtains? Whatever it is, okay. And then make sure they get on a proper sleep cycle. Okay, very, very important. Okay, make sure they're falling asleep at a specific time every night. Okay, that way they can wake up at a certain time. Okay, that getting into a rhythm is very, very beneficial, and everyone should be into that at some point. And once you're in like college and high school, everything sleep goes out the window. Once you have kids, it's just like screw it. I slept 4 hours a night. It was great. Okay, and then medications. Okay, what medications are you taking? Okay, unless prescribed by a doctor, you should avoid ibuprofen or Aleve. Okay, or naproxen. Okay, all those NSAIDs, okay, are blood thinners. Okay, which can be detrimental. Okay, unless the doctor says okay, you can take them, then you can take them. Okay, but your go-to med, and you don't abuse it. Okay, take as it says on the label, is acetaminophen or Tylenol. Okay, that is the pretty much choice of medication to take, unless the doctor says you can take this or that or whatever. Okay, and then the last thing is physician referral versus ER. Okay, this is going to depend a lot on the situation. Okay, given, and I don't want to deter everyone from the ER, but let's not waste resources on people that don't need it. Okay, ER is second to none at saving your life. Okay, most concussions or mild traumatic brain injuries, okay, don't need an ER. Okay, you will live. Okay, you'll have great outcomes. Okay, and if you do go to the ER, what are they going to do? They're going to do an X-ray. They're going to do CT or MRI. Okay, rule out life-threatening items. Okay, and they're going to say, all right, go make an appointment with your regular physician. Okay, that's what they're going to do. Okay, if you have a life-threatening condition, okay, or that concussion is like really bad, you have vomiting, loss of consciousness, everything else, absolutely ER. Okay, but if not, go home, rest, get some sleep, eat, and then make an appointment with your doctor. Okay, or a trainer or whatever your circumstances are. Okay, really, really important. But let's not waste ER resources because it's very limited. Because if you've ever been to the ER, okay, you've probably waited there for 8, 12 hours sometimes. Okay, so if it's not like ER like worthy, okay, if it's not life or limb, they're like, all right, we'll stabilize you, and then make sure you follow up with your primary care. Okay, so again, I don't want to deter you from going to ER, but if you can make an appointment with your primary physician or urgent care, which is great, okay, do that. Okay, and a lot of physician offices have an urgent care attached to it now. Okay, because it's not an ER, but you may like get in with a physician could take, let's say, a broken limb, could take a week. Okay, urgent care is great. Okay, they still have physicians there. They see pretty much everything. Okay, and usually your wait times are not as long. Okay, especially if you call in advance, say, hey, I'm coming in for this or that. Should I go here? Should I go there? Where should I go? They're like, all right, come here or go to the ER. They'll tell you straight up, and they'll look at you, and if it's beyond the capabilities, they'll send you to the ER. Okay. All right, then what to do? Okay, so someone gets a concussion, removed from activity. Okay, eliminate outside stimulus, whatever that is. Okay, rest. Okay, but get appropriate rest. Okay, refer to some kind of healthcare provider, whoever it is. Okay, severe. Okay, ER, obviously. Okay, activity-wise. Okay, it was no activity. Okay, so now we're adding inactivity. but as part of a concussion rehab. I'll talk about that here in a little bit. No ibuprofen or Aleve or naproxen. And then you always want to do a return to learn before a return to play. All right, so acute injury post-incident observations. Okay, so this is like right after injury occurs. Some really important things to keep in mind. Okay, one is mechanism of injury. Okay, how did it happen? Okay, knowing like the history of how it happened is 90% of it. Okay, they fall, they hit their head, someone hit them, car accident, whatever it is. Okay, can help kind of paint the picture of what could potentially be wrong. Okay, really, really important things. Okay, and then like getting in depth, like how it happened, if you have time. Okay, was it a car accident? How'd you get hit? Okay, from behind and front, did you hit someone else? From the sides, did you spin? Did you roll? How many times? That kind of stuff. Okay, next is excuse me, battle signs. So battle signs is here. Okay, this could be the base of the skull, okay, bruising. This indicates the base of the skull fracture. Okay, so like the occipital bone, okay, down here at the base of the skull is fractured. So let's see a lot of discoloration and bruising. Okay, very bad thing. Okay, that's called battle signs. Next is raccoon eyes. In here, looks just like this. Okay, so raccoon eyes is intracranial bleeding somewhere. Intracranial hematoma, but blood can't go anywhere. The only spot where the blood can go is out the eye sockets. Okay, that's where they get this raccoon eyes here. Again, a very bad thing. Check the ear for a clearish fluid, okay, which is the cerebrospinal fluid, the fluid that's within the brain. Okay, if you're leaking, that's a very bad thing. Okay, the fluid is more like an oil. It's light to, someone told me, like a very light, clear to a light yellowish. So one thing that they'll do is what's called a halo test. I have this there. Okay, so usually if we're leaking CSF fluid, that was right. There is going to be bleeding somewhere. So what they do is they'll take a gauze pad. We have one. Let's use a napkin. Okay, they'll take a napkin like so, and we'll fold it twice. Okay, and in the center spot, okay, they're going to dip in any blood that's around there. Okay, you don't need a lot, just a little bit, and then they're going to dip it again. This is a little area here in the ear. Okay, and take it out. And because blood is like water-based and CSF is oil-based, what it's going to do is going to push all the blood out, and you're going to get this halo effect going here. Okay, and that is a quick, easy indicator of a CSF leak, which is really bad. Loss of consciousness, LOC, which can also be defined as level of consciousness. So just make sure that whatever the question is, you're identifying which one that is. Okay. Diminished general appearance or vitals. Okay. Is their appearance getting worse? Okay. Are their vitals getting worse? Okay. So you should take vitals as soon as you can. Okay. Someone's asking questions. Someone's doing vitals. Okay. If they're not really stable, okay, how are the vitals changing? Usually about every 5-10 minutes, not about 5 minutes, retake vitals. Okay. Are they getting worse? Okay. Are they getting better? Okay. Things to keep in mind. Intervention. Okay. 911. Okay. Do you have to do CPR at some point? Okay. Mantra ABCs, okay, every breathing circulation, that's just going to, you've got to do CPR or not. And then Pearl, okay, which is the eye check. Okay, pupils equal and reactive to light. Okay, that's where flashing a little pen light in the eyes. How much time? Oh, an hour. All right. Next is some neurocognitive testing that you can do. Okay, so this is once the cornerstone of concussion evaluation in 2001. It is now not so much. Okay, so this is a lot of the impact, scat tests, so forth. This will change in the next year. I'm anticipating. I don't know how it's going to change yet. It is used to aid in clinical decision making, but given aid is the key word there, but not replace. Let's say we used to do a lot of preseason versus postseason or post-incidental testing. So like baseline is a big one, which isn't a bad thing. So we'll see how you are normally, and then we'll, after an injury, we'll take another one, and then we're going to see how that changes. Okay. Now it's going to be no longer required. Okay, just because it can vary so much. Other concussion tests will be out there, which there's a lot. Okay. Impact test, it's a computerized test. The SCAT series, we're currently in SCAT 5 right now. VOMS, it's more vision, ocular, motor screen, I believe. And again, there's a ton more. So concussion testing, okay, so the SCAT 5 is an on-the-field evaluation test. It's a written test. Pretty much every concussion expert in the world got together and they made this. And we're in the 5th version of it. And they're all pretty similar. Okay, so it's comprised of a symptoms evaluation, Glasgow Coma Scale, MAC score, okay, which is like a sideline assessment, old school, balanced error scoring system, and a standardized assessment of concussion. So it's a bunch of little tests combined. Okay, so here's the majority of symptoms of a concussion. Okay, there are going to be a few more in here, and again, they don't have to have all of them. But pretty much all the testing now is on a 0 to 6 scale, not 0 to 10. Okay, keep that in mind. So 6 is the most extreme, not 10. Okay, so headache is usually the number one symptom of all concussions. I have seen some concussions to where there was not a headache. Okay, really rare. I think there's only 2 out of like the hundreds I've seen. But it was very interesting to work with. Okay, so headache, pressure in head, neck pain, nausea or vomiting, dizziness, blurred vision, and again, this is part of like the SCAT 5, for example, right now. And so for all these, you're going to say like, hey, I'm going to read you a list of symptoms, respond back of how you feel right now, on a 0 being nothing or 6 being the most severe. Okay. And then you're like headache, and we're like 2. Pressure in head, 1. Neck pain, 0. Nausea or vomiting, 0. Dizziness, 3. Blurred vision, 2. Balance problems, 6. Okay, for example. Okay, you can go through it. Okay, so balance problems, sensitivity to light or noise, feeling slowed down, feeling like in a fog. Okay, which is oddly enough, I can't describe it too well, but you feel very like, I guess foggy is a really bad way to describe it. You would don't feel right, difficulty concentrating or remembering, fatigue, low energy, confusion, drowsiness, trouble falling asleep or staying asleep, more emotional irritability, and nervous or anxious. Okay, so those 22-ish are the most common signs of a concussion. So next is the GCS, the Glasgow Coma Scale. This assesses the level of consciousness. Okay, 15 being normal, 3 being unconscious or dead. Okay, this is more of your observation. So usually in most of my classes we've covered this during vitals, but if not, I'll go over it briefly here. Okay, so it takes into 3 different factors. Okay, eye-opening response, verbal response, or motor. Okay, I don't know why I have this double up here, but they get 4 points if their eye-opening is spontaneous. Okay, like anyone else, like you say their name, ask them how you doing. If their eyes are open, okay, pretty normal-ish. Okay, they get a 4. Okay, they'll get 1 out of each section. Okay, and you add them up. Okay, it's like 4, 5, and 6 added up to 15. So you know. Okay, so you get 3 points if it opens to verbal command, speech, or shout. Okay, if their eyes only open to pain. Okay, again, do not apply pain to the face. Okay, and they get 1 point if their eyes don't open, no matter what happens. Okay, verbal response. Okay, they get 5 if they're oriented. Okay, ask them a question. Hey, how are you? Not feeling so good, but going. Okay, cool, great, 5. Okay, oriented. Okay, they get 4 if they're really confused. They get 3 if it's inappropriate words. Okay, words that are just not like put together. They're like scrambled up. 2, okay. If you can't understand anything they're saying, okay, they're speaking straight Klingon. Okay, they get 2. Okay, and then 1 if there's no response. They could look at you and nothing happens. Nothing comes out of their mouth. Okay. Next is Miller. Okay, so you get 6 points if they obey commands. You reach out your hand, they shake it. Hey, how are you? Hey, can you sit down? Can you lay down? That kind of stuff. So you get 6 points, easy. Okay, 5 points if moves to localize pain. Okay, so if I'm going to like hit them or poke or like stab them, okay, let's say a fork. Okay, if I'm going to stab them, they're going to move away from it. Okay, because obviously they don't want to get stabbed. Okay, 4, they withdraw from pain. Okay, so you're going to pinch them and they kind of move away. Okay, almost like delayed. 3, abnormal flexion, or 2, abnormal extension. Okay, both of these, the decorticate like postures or disordered postures are really bad. Just know that. Okay. 3 is they're more everything's gonna go into flexion. Okay, you're kind of go up like this. Okay, knees are come up almost like the fetal position in a way. And then 2, I don't know why my computer's loading. The extensor response is they're go out really wide. Okay, like this. And then 1, there's no motor response. Okay, so most of this is mainly your observation. It's going to take maybe 30 seconds to identify the GCS, or level of consciousness. Okay, max score. This is a traditional sideline assessment. It's not the best. Let's know that. I wouldn't be surprised if they remove it completely from the SCAT in the near future, because it's questions which aren't bad. You can change the questions, but they're not really that accurate to help you assess for a concussion. Okay, so like, where are you today? Okay, what half is it? Who scored last? Okay, who'd you play last week? And did you guys win? Okay, not the best questions because they're very subjective. Okay, maybe they weren't there the last game. Okay, they're out sick or whatever happened. Okay, maybe they have no idea what half it is because a lot of people, they don't really pay attention. Okay, it's not the best thing in the world. Okay, next is the BEST, the Balanced Error Scoring System. So this is a balance test. It's actually 3 balance tests. Okay, for 20 seconds each. Okay, and then it's you are allowed 10 points automatically, and for each like error that you have, 1 point is deducted. Okay, so first is double leg stance. Okay, so you stand feet together, hands on your hips, looking straight ahead, and then you actually close your eyes for all these. Okay, so just a double leg stance. Okay, feet together side by side. Close your eyes. I usually are going to be pretty close to the person behind them in case I need to catch them. Because if their balance is off, they're not going to know that they're falling. Okay, so you may need to catch them. Okay, next is single leg stance. So to do this, you say, all right, if you kick a ball, which leg would you use? And you say, oh, I'm going to use my right. Cool. Now you're going to stand on your left leg. Okay, it's a single leg stance. Hands on your hips, close your eyes, again for 20 seconds. And each point deducted is if a hand comes off the hips, if their eyes open, if they stumble, if they put a leg down, for example, in this one, to catch themselves or whatever. Okay, that's 1 point. Okay, allow them to return back to normal stance, keep going, but they can only miss 10 per test. Okay, next is a tandem stance. Okay, so it's heel to toe. Okay, so the non-dominant, so the one they use for the single leg stance, is going to be behind the other one. Okay, same thing, hands on your hips, close your eyes. And you can adjust the best depending on the individual. For example, if I have a gymnast, okay, I'm doing the best, their balance is exquisite. Okay, naturally. They have to have amazing balance. Okay, so I'm going to add a foam pad underneath your feet for all these. Okay, because even when their balance is like off, their center of gravity is off, like in their head because of concussion, they can still do pretty well in some of these. just because of how they train. Okay, next is a coordination exam. Okay, this is upper body coordination. You stand, sit. So I'm going to hold one hand out here, like this would be like me. Okay, the person's here. I'm going to do 5 successive finger to nose touches. Okay, so like this is here. Okay, I'm going to be. That's it. Okay, they have like 3 seconds to do it. Okay, and keep in mind, like, are they hitting like your finger? Are they hitting their nose? Are they poking eye out? Okay, how is their coordination on this? You're holding out with probably like a foot away from the nose. Okay, next is the last part of this is the standardized assessment of concussion. Okay, so this given for all these, not everyone's getting 100%. I've never seen 100%. Okay, even on doing baselines for people. Okay, so orientation. Okay, what's the month? What's the date, day of the week, year, time, example right now. Okay, and time they have to be like within a few hours. Okay, and if it's during a game, okay, they're actually pretty good at this. Like, all right, game starts at 7, it's halftime, it's probably 8:30. Okay, so they'll be pretty close on this. Okay, memory. Okay, 5 random words. Okay, and if you ever look at the SCAT, like SCAT 5, for example, it's going to give you a number of different like word banks you can use. Okay, you can use, I think it's like 6 of them that you can use, give or take. And depending on how many concussions that person's had, I'm going to vary the word banks, and I'll just like circle which one I'm using for this test. Okay. So, all right, please remember these words. Okay, and I read them like very carefully. Okay, elbow, apple, carpet, saddle, bubble. These words off SCAT 3 because I did a lot of SCAT 3 before the SCAT 5 came out. Okay, and then I do it again. Okay, remember these words: elbow, apple, carpet, saddle, bubble. Okay, and then they repeat back to me. Okay, each time. Sorry, I didn't say it the first time. I think the third time. Okay, remember these words. Okay, elbow, apple, carpet, saddle, bubble. Okay, remember them. Okay. And then do concentration. So you're going to say numbers in reverse order. For example, if I say 493, they say 394. So if I say 1, 2, 3, 4, they say 4, 3, 2, 1. Okay. So if I say 6, 7, 2, 8, okay, you would say, and how about 9, 2, 1, 5, or 6, 7, 8, 5, 2. Okay, you have to say those in reverse order. Okay, not the easiest thing in the world. Okay, and then tell me the months of the year in reverse order, starting with December. Okay, can you do it? Okay, and then do you recall? Okay, what were these 5 words I said to you earlier? Okay, tell me in any order. Okay. Okay, so that is the SAC. And a lot of these different like areas of this are used on other aspects, other tests. Just know that. The next one is the impact test, immediate post-concussion assessment and cognitive test. Okay, for one, it is not a like actual impact. No one's being hit, whatever. I just a comical picture that I found. Okay, so the impact test is a computerized neurologic test. Okay, used for concussion evaluation. Okay, there's a symptom scale identical to the one we just went over. Verbal, visual, memory, processing speeds, number of different tests. It takes about 30 minutes to do. It takes reaction time down to 1/100th of a second. Okay, so how fast can you respond to this? Okay, you can do mass baseline testings. Okay, all you need is a computer with internet access and a mouse and a keyboard. That's it. Okay. Does not diagnose for a test. Okay, does not diagnose for a concussion. So you can do a lot of baseline and post-concussive testing. Pretty widely used for the most part. A lot of different organizations, all like professional, high school, middle school, use this. Okay. If you ever played sports, you probably took something similar to that. and then after a concussive blow, like you'll take another one. And usually like do like a baseline every season. Again, you don't really have to do baselines anymore. Okay. Very accurate, spits out 6 pages of results. Okay, a lot of results. How fast did you respond to this? How accurate, and how was your speed on this? A lot of different things. Okay. Next is Pearl. Okay. Okay, so this is one of the vital signs I usually cover in class. Pearl is pupils equal and reactive to light. Okay. This is where you take a pen light. Let me have one in here. Okay. Your lights are off. I'm going to take this. I'm going to slide it over one eye. Okay. Just so you bring the lights on. Okay. So you see how quickly my pupils constrict. Okay. Then I go to the next one and make sure it constricts evenly. Some people have a condition called anisocoria, which their pupils are not equal, like this. Okay. And they're going to know if they have this because at some point, someone during some kind of test, they'll be like, "You're screwed up." Okay. But no, it's just how they are. Usually this is going to indicate some kind of brain injury, stroke, number of different things. Okay. Well, one eye constricts and the other one does not. Okay. You can also do eye tracking, side to side, up and down. Okay, I'm not going to be really in depth in this class on that. Okay. This is just the video showing all that. This is just a procedure for going over it. Given we'll do this in class if we have not already on how to check the reaction time. Okay, so best testing methods. Okay, there's no one test is sufficient or is better than the others. Okay, it can be a number of different tests through a very in-depth clinical evaluation. Okay, must consult a physician, MD or DO, and coordinate with any kind of treating team physician and so forth. Okay. All right. So emerging areas of concussion information. Okay. There's a lot of stuff's going to change. I mentioned some already. Other things that are going to change is they're in a biopsychosocial model. Okay. Biologically, psychologically, and social areas that can be affected. Active rehabilitation. Visual vestibular assessments. Prognostic factors. Mental health considerations. Phenotypes of concussions. They're looking at genetics now. You're more genetically predisposed to be in this factor, that, and so forth. A lot of information. The nerd in me kind of freaks out a little bit about it. Okay, so the biopsychosocial model, okay, has 2 different parts: the biological and psychological. Okay, and then there's the social one I'll talk about here next. So the neurometabolic cascade post-concussion. So I talked about that cascade that happens after an injury. Okay. So the primary elements of the psychosocial cascade following concussive brain injury includes abnormal neurological depolarization. Okay. That is that action potential. Okay. Or that nerve stimulus. Release in excitatory neurotransmitters. Ionic shifts, changes in glucose metabolism, altered cerebral blood flow, and impaired axonal function. Okay, so a lot of different things are affected. Okay, early exercise may provide psychological adaptations to improve outcomes. Okay, so some early exercise is important. Okay, but it's very detailed in what that means. Okay, some seen cognitive issues, motor balance issues, visual or vestibular balance issues, okay, are all biological. Psychological, okay, anxiety, depression can be seen, mood considerations, how to integrate them back into social activities, okay, without exacerbating symptoms that may improve treatment. Exercise and rehab can affect psychosocial, okay, our qualities of life, peer support, behavioral therapy, treatments, whatever it is. Okay, peer support is actually really big. Okay, if you're on a athletic team, okay, are your teammates supportive or are they not? Or are they giving you crap for being out? Okay, if you've been on a team, you've probably either seen it or been part of it. Okay, Either way, okay, whether it's giving crap for being out for a concussion or being supportive, okay? Being supportive is really beneficial, okay? And it can actually improve them getting back faster. Because one big area is, okay, is the stress aspect post-concussion, okay? That really plays a factor. Is it stress from having a concussion? Is it stress from like school issues, from family issues, from team issues, okay? And all that stress just kind of builds and builds and builds on a brain that's already susceptible to everything, and it prolongs everything, okay? Next is the social aspect, okay? It's the peer teammate family interaction, engaging in daily social activities without making your symptoms worse, okay? So make sure they can still do their social items, okay, without making things worse, okay? So obviously, don't go to any raves, okay, because that's probably going to make things worse. But they still like going, playing, like hanging out with friends. Cool, as long as it doesn't make it worse, by all means, okay? Rehab is a means of social interaction, okay? So going and hanging out with like their friends, having them over, like chilling, whatever it is, okay, can be a part of rehabilitation, okay? Social support, blah. And school and work considerations, more of that return to learning that we talked about before. Okay, some concussion subtypes or phenotypes. Okay, there's cognitive, affective, vestibular, ocular, headache, migraine, and sleep disturbances. And what they found is in adults there's more cognitive, okay, phenotypes that occur, but with adolescents you need more vestibular or headache migraines, okay, that are triggered. Okay, this area is going to be very important here in the next immediate future, and more research to come. Okay, so cognitive phenotype, okay, again, happens in more adults. Symptoms: feeling in a fog, difficulty concentrating, memory problems, feeling slowed down. Okay, so if you ever had a concussion or multiple, okay, see what areas you kind of fall on. Okay, clinical exam, neurocognitive defects, multiple domains can be affected. Risk factors: personal history of ADHD or learning disabilities. Target treatment, okay, academic supports, behavioral regulation, and they can even have medication, okay, as needed. Affective phenotype, okay, symptoms: anxiety, depression, worry, difficulty turning off thoughts, focus on symptoms, panic attacks. Okay, so clinical exam, elevated scores above the cutoffs. And apparently not a finished sentence. Okay, risk factors: personal or family psychiatric history or medications, comorbid migraines or sleep issues, presence of significant life stressors. Okay, targeted treatments: psychotherapy, approaches, behavioral activities, behavioral therapy, exposure therapy, psychotropic medications, okay, a number of different things. Okay, vestibular phenotype, okay, symptoms: slow, wavy dizziness with movement or changes in position, balance problems, motion sensitivity, vertigo when laying down, looking up, or rolling over. Clinical exam: abnormal vestibular screen, symptoms: provocation with vestibular ocular reflex test. Okay, don't worry about some of this. Risk factors, okay, personal history of motion sickness or sensitivity, personal history of vestibular disorders, comorbid migraines, anxiety disorders. Treatment's going to be balance therapy, dynamic exertional therapy, exposure recovery approach, and day-to-day activities. Okay, ocular phenotypes, okay, do you want vision? Okay, symptoms are going to be blurred vision, double vision, diplopia, eye strain. Okay, do they wear glasses? Do they not? Do they need glasses? Okay, difficulty focusing, headache, fatigue triggered specifically by visual activity. Okay, how much do they have to look? Okay, so you got to think in a normal class setting. If there's something on a projector, okay, PowerPoint, whatever it is, okay, up on the wall, okay, you're looking distally, okay, at an item, and looking down to a more an item that's closer. Then back and close, back and close. Maybe writing, whatever it is. Okay, so they can't do that. Okay, that change from far to near, far to near, far to near. Okay, throws them off. Okay, now they got to focus on something far away, then closer, far away to closer. Okay, and for one, where are they sitting? Are they back at class? That can make it worse. Are they in front? Maybe it's still better, but now they're going from a really big font to a really small font, really big to small. Okay, and so forth. Okay, so maybe tell them focus on just one. Okay. Okay, clinical exam, abnormal near-point convergence measurements. Okay, tracking saccadic deficits, neurocognitive defects, risk factors are not established yet. Okay, personal family history of eye muscle surgery, a number of different things in there. Targeted treatments, okay, vision therapy, exposure recovery approach when engaging in visual demands. Okay. Headache migraine phenotype. Okay, symptoms are going to be intermittent, moderate to intense headaches, often present on waking. Okay, so headache as soon as they wake up. Okay, headache with nausea and with either light or noise sensitivity. Okay, visual aura including flashing or shimmering lights, zigzag lines, stars, pulsating quality, motion sickness, sleep comments can be pretty problematic. Okay, clinical exam, neurocognitive defects across a number of different domains. Risk factors, personal family history of migraines, history of motion sickness, could have anxiety disorder, sleep problems. Usually are very common in females. I couldn't tell you why yet. This study on all these, they've only released part of it out. Okay, so I'm still waiting for more to come out. A lot of it's going to be this next fall when everyone meets. Okay, targeted treatment, referral to headache specialist, behavioral regulation. Okay, so active rehab. Okay, so this is a big thing on actually doing physical activity. Okay, as part of treatment for the brain. Okay, rehab for the brain. This is not going back to activity. Okay, the whole return to activity is usually like a 5 or 7 step process. Okay, which each organization is a little bit different on. Usually, it's going to be the first step is going to be no symptoms. Okay, next step is going to be 20 minutes aerobic light activity, and then it progresses up to there. Usually, the last step, is a full non-restricted practice. Okay, before they're fully released to a game. Okay, and those vary depending on like high school and college. It change. They vary, but they're very similar. Usually, the return to play is not 5 or 7 day. Okay, big misconception on that. Okay, there's no 5 to 7 day. It's 5 or 7 steps. Okay, each step could be 1 day. It could be 3 or 4 days. It just varies. Okay, and you never skip steps. Okay, but the active rehab, we're using activity as part of the rehab for the concussion, but not necessarily part of the return to play. It could be, but this is a very structured thing. Okay, and more information will come out. I have a few examples in here. So the physical portion of this is going to be to maintain fitness levels. Okay, physiological functions of exercise. Okay, rehabilitation of affected systems. Okay, for example, when I mentioned cerebral vascular systems could be compromised after a concussion. Okay, well, activity can help push blood flow to all those different areas of the brain and revascularize those areas. Okay, that's one big major component of exercise. Okay, psychologically, improves compliance with the rehab, removes isolation. Some people after an injury, okay, they get very isolated. Okay, not everyone. Okay, they don't want to go anywhere. They don't want to do anything. They want to stay at home in bed and eat ice cream. Okay, usually without the ice cream component, but they don't want to do anything. Okay, so it gets them out of like the house, get them moving again. Okay, helps reduce anxiety. Okay, a lot of people are really bad issues of anxiety, whether they fess up to it or not. Okay, this can help kind of get them like moving, helps reduce all that. Okay, and they get a lot of these psychological benefits of exercise, which pretty much everything I mentioned before. Okay, one thing is the Buffalo Concussion, a treadmill or bike test. Okay, they have both. Very similar. What it is, it's a 20-minute test, treatment, however you want to determine it. On each minute increases in usually intensity. And the treadmill is not running, it's walking. Okay. Only difference is incline. Okay. Increases and sometimes speed. Okay. But I mean, you can Google it. You can download the whole assessment. It's free. It's up there. And it tells you like there's different things like they have to grade on, like what's their exertion, depends on their symptoms, have that changed, depends on the intensity. It usually takes about 2 people to administer it. Okay. So that's a video that doesn't play for this right now. But you can like look it up, it's on YouTube. So early supervised exercise, okay, for one, that have to be usually around 16 years old at least. Okay. Similar initial symptoms on severity score. And tolerate at least 10 minutes of aerobic exercise, whether it's a treadmill or bike. Okay, so they may be able to do that. So some differences that they're seeing is time start of early supervised exercise. Okay, can have a 11-day return versus a 29-day return. Okay, so it can shorten your return to activity by a lot. Okay, the clearance, so return to play. Okay, we have 26 days and we have 35 days. Okay, a day symptomatic. Okay, so doing early supervised exercise, 16 days to 22 days non. Okay, so you see vast increases. Okay, and why early supervised exercise is really, really important. And a form of that is the Concussion Buffalo treadmill or bike test. All right, exercise interventions. Okay, so a lot of different things that go around treatment. Okay, so one has to be supervised no matter what. And this is not a coach supervising it. Okay, this is most likely like an athlete trainer or a physician doing this. Okay, and not them doing on their own. Okay, it's not the same thing. Okay, it is not a exercise that you would think of. It's more of a structured item. Okay, so documentation. You have to document everything that you do. Okay, type, duration of exercise. Okay, heart rate, blood pressure. RPE is perceived exertion. Okay, symptoms. Okay, what level of symptoms? How many symptoms? So forth. Okay, this is documented like not just once. Okay, sometimes multiple times during each exercise. Progressive. Okay, initially do not stimulate visual field and vestibular field. Okay, initially. Okay, wait a little bit before you start doing that, and then progressively add in those stimulus. Okay. Multifaceted, okay, so usually it's aerobic, okay, but you want at some point you want coordination to be stimulated, visual, motivational, educational aspects. So it's not just one different thing. It's not just one thing. It's a number of different things. Okay, make sure it's very planned. Okay, avoid stimulating brain activities that are correlated to symptoms. Okay, so if something's going to cause that symptom, okay, let's not do it. For example, if vision causes headaches, for example, let's not do anything involving vision. Okay, and sleep. I talked a little bit about sleep. So sleep is one of the first things. Okay, for one, do not withhold sleep. Do not keep them awake. Okay, that's the worst thing. So sleep systems regarding arousal, alertness, attention, and sleep are vulnerable to traumatic brain injuries. Okay, so They may have a hard time staying asleep. They may sleep for long periods of time, or a number of different things. So it could be altered. Okay, sleep disturbances are associated with greater symptom burden, and lower cognitive scores. Okay, so as much sleep they can get, the better. Okay, again, do not withhold sleep. Okay, they will not go into a coma. Sleep is the best rest. Okay, and the sleep hygiene. Okay, it's a loss up in here. I apologize. This is just really good sleep hygiene to do. Is keep a consistent sleep schedule. Get up at the same time every day, weekends and during vacations. Set a bedtime that is early enough for you to get at least 7 to 8 hours of sleep. Okay, don't get to bed unless you are sleepy. If you don't fall asleep after 20 minutes, get out of bed, do a quiet activity without a lot of light exposure. Especially important to not get on electronics, okay, which is really easy nowadays. Okay. That could be like read a book, like a physical book. Okay, help you sleep. Okay, establish a relaxing bedtime routine. Use your bed only for sleep or sex. Okay, that's it. Make your bedroom quiet and relaxing. Keep the room at a comfortable, cool temperature. They're finding that 65 degrees is some of the ideal temperatures for sleep. Okay, it's a little bit on the cooler side, but they're having better sleep as a result. Limit exposure to bright lights in the evenings. Turn off electronics at least 30 minutes before bedtime. Don't eat a large meal before bedtime. If you're hungry at night, eat a light, healthy snack. Usually something with not a lot of carbs, usually high protein, high fat. Exercise regularly and maintain a healthy diet. Okay. Avoid consuming caffeine in the afternoon or evenings. Avoid consuming alcohol before bedtime, and reduce your fluid intake before bedtime. Okay. Come on. All right, return to learn. Okay, I mentioned a little bit earlier. I'm going to go to some other items. So general adjustments. Okay, transportation to and from school. Okay, they should not drive if they have any kind of concussion symptoms. Okay, the bus might be overstimulating for these individuals. Okay, I mean, take an Uber if you're like in college. Have your parents pick you up. Have a teammate or a I'm drawing a blank right now. A roommate pick you up. Okay, alternate mental rest with mental exertion. Okay. Avoid prolonged periods of exertion. Increase exertion, decrease rest as tolerated. Okay. Avoid overstimulating environments. Okay. Cafeteria, hallways, beginning in a class. I mentioned some of this previously. Physical symptoms adjustments. Okay. For headache, frequent breaks. Reduce exposure to anything that aggravates that headache. Rest in nurse's office or athletic training facility. If they have dizziness, allow students to put head down. Early dismissal between classes to avoid crowds. Visual symptoms, reduce exposure to computers or videos. Reduce brightness on screens. Allow them to, allow hats or glasses. Audio tapes for books if they're available. Now, cognitive symptoms, okay, difficulty concentrating. Avoid testing or major projects, okay, or push them back. Okay, extra time for set items, homework, so forth. Consider having a note taker. Notes, scribe, someone to do that for you. Okay, so here at the college, we actually have that. So if anyone that has or goes to like DSPNS for any kind of like injury, neurocognitive issues, whatever it is, okay, and the physician like signs off on it, you can have a note taker. So a lot of time you may hear like instructor beginning a semester like, hey, is anyone willing to be a note taker for someone else? A lot of times you're not going to meet the individual. Sometimes they could. They'll take notes for them. That way they don't have to concentrate so hard. Okay. Mentally foggy. Okay. They'll need more breaks. Simplify tasks. Okay. If they have difficulty paying attention, have them sit in the front of class. Okay. That way, if there's any distractions from the students, okay, it's all behind them. Work in a quieter room if possible. Okay, emotional symptoms. Okay, anxiety, reassurance, workload reduction, alternate forms of testing, face-to-face, verbal questions, non-written, that kind of stuff. Depression, build time in for socialization. Okay. DSP&S office is really great for depression, anxiety, other things. Sorry, not DSP&S. Psych services. Sorry. Psych services is on campus here at Fresno City. They do a amazing job. Okay, for depression, anxiety issues, whatever it is. I have sent a number of people there. I've walked them over because it's a little like scary, intimidating. Like, oh, I'm going to go see a psychologist. They do a great job with this. They're not going to think you're crazy. They do a really good job, especially for anxiety factors. They can give you or help you with different like tasks to help you reduce your anxiety over a said like item. Okay, which can help your concussion symptoms tremendously if you don't have that anxiety. Because some people have like really high levels of anxiety, whether they already see a psychologist or whatever it is. Okay, next to someone on campus, they can further help you with it. And for one, if you're a student, it's free. Okay, if you're not a student once you graduate, okay, it's usually pretty expensive sometimes. Okay, but it's free if you're a student. And even once you graduate, they can help you with different services. That way it's either like lower cost or whatever it is, or help refer you to someone else outside of campus, that kind of stuff. Okay, but depression, they're a great resource. Talk to someone, talk to an instructor if you're concerned about anything. If you just want to keep it kind of to yourself, you want to go up and see them. Okay, Psych Services is above the bookstore. It's kind of weird how I get there. It's on the upper level. So over by the Ram Pantry, there's a stairway that goes up, or there's an elevator. Either one takes you up there. And it's all the way on the north side of that kind of hallway. I mean, you just like walk through, like there's signs everywhere. Go and like talk to them, like they're super friendly. I've worked a lot with like the athletic teams on campus for a number of different things. Okay, they're a great resource. Okay, but by all means, like hit them up. Great people. Anyway, okay, so they're good for anxiety, depression. If you're more emotional, okay, have a signal with a teacher, like, hey, I need to leave. Okay, or you go rest. I've had people that are like, hey, I'm just gonna get up and leave. I'm like, that's fine. Okay, they'll text me later, whatever it is. Maybe they won't have a signal. They'll just like email me later, like, hey, I'm sorry, something triggered something, and so I just leave. It happens. Okay. But usually, like doing something like privately ahead of time, like through an email to the teacher, whatever it is, instructor, says, hey, I got to take a little break. Okay, go to your car, chill for like a little bit. Some people come back in for some like my longer classes, or after the fact, or sit in like another class, whatever it is. Okay, adjustments for sleep symptoms. Okay, so your sleep disturbances allow for a late start or shortened day. Allow for breaks. If they have fatigue, strategic rest, schedule adjustments as needed. Everyone's going to vary a lot on that. Visual dysfunction following a traumatic brain injury. Okay, which is any disorder of your vision. Ocular motor, accommodation, spatial, photosensitivity, number of things. Okay, so visual symptoms are very common in brain injuries. Okay, it contributes to headache, dizzy, eye fatigue. Can be as much as 79% of all patients that have a concussion. Okay, can affect school, work, driving, other assisted daily living items. Okay, so your visual things is very, very important. Okay, and should be approached specifically. Okay, so computer use, line guides, color tints can help, increasing the font size, decreasing brightness, anti-glare screens, that does exist, reduce any kind of glare, rest breaks, and education on managing symptoms. Don't try and just power through. Okay, take little breaks here and there, because it could take a while for you to build up that capacity again for all that increased stimulus afterwards. Okay, so if you have to use a computer, which is very common nowadays, or your phone or whatever it is, you have to do it in like segments. Okay, I'm going to be 10-15 minutes of homework on my computer. All right, I'm going to take a 5-minute break. Okay, 15 more minutes on computer, 5-minute break, so forth. Okay, and then as you progress, I can move up 30 minutes on the computer. Okay, with a 5-minute break, a 10-minute break, whatever it is. Okay, and again, a lot of this information is going to change tremendously in this next year. This is a little bit like a gap in between of what they're kind of start pushing. The nerd me is kind of like looking forward to what we're going to see in the next year, but it's going to be pretty groundbreaking in terms of some of the concussion stuff that we have been doing.